I think we'll make a start. Welcome everyone and welcome to colleagues online. I'm Athena Blahantoni. A very warm welcome to Bohu from the London School of Economics. This is a joint seminar from the Center for Research on Aging and the Center for Population Change Connecting Generations research program. Both centers conduct research which is along the lines of your work, Bo. I've known Bo for many years. We've seen each other in lecture theatres from afar. We've talked a little bit, but it's the first time he's our captive audience here, captive in this room for an hour. So I'm really, really pleased and delighted to welcome you. He's going to speak on costs of long-term care, which I know colleagues around the room are working on. So we're all very excited to welcome you. Thank you for coming.
Thank you.
Over to you.
Thank you very much. And thank you for Athena and colleagues for inviting me. It is really truly an honor to be able to have this opportunity to give this presentation in the seminar series here. And today, what I'm going to talk about, well, my background is economics and social policy. My research areas are long-term care utilization, long-term care financing, and care provision. Today, I'm going to talk about is to look at the interactions between two very important social policy areas, that is housing policy and long-term care policy. What I'm going to talk about is we had a study where we had an investigation to look at the future cost of long-term care and the different hypothetical housing intervention scenarios. This study is part of the project called Care and Place, which is funded by National Institute for Health and Care Research, School for Social Care Research. Apart from myself, we have Nicola Brimble-Gumby, who is our PI of this overall project. Javiera, Martin, Jadita, Madeline, Wagner, and Sherry contributing to different parts of this program. So we all know that long-term care is crucial to older people, especially for those who experience a decline in functional capability for activities of daily living, such as dressing, eating, and shopping. And home care services. We're also referring to unpaid care. This is the type of care provided by family members, by relatives, by friends, and even neighbors. Due to population aging, we have seen that demand for long-term care has been increasing, and we expect that it will continue to increase rapidly in the following decades. Not only in England, in the UK, it is happening in most part of the world. So in this context, it is important to have a better, we think it is important to have a better understanding of future costs of long-term care. Also because this is useful for care planning and resource allocation. We want to make sure that we stay ahead of the curve. So we know how the costs will change. We just put in resources in place ahead of the incoming changes. And this is also important for mitigating unmet care needs, because we need to make sure sufficient resources are put in place, because service delivery takes time as well. And it is also important for reduce demographic, socioeconomic, and geographical inequalities in terms of access to care and support. Based on that, we are also interested in understanding better the future costs of long-term care, because we want to figure out feasible ways that can help us reduce demand and on that basis, reduce long-term care costs. And we think one way to do this is to figure out feasible interventions or policy measures to prevent the onset or delay the progression of long-term care needs. Then that can help to reduce it, because people are getting healthier, help reduce care demand and reduce care costs. Determinants of health. In the UK context, it is reported that up to 50% of residential dwellings do not meet the decent home standards. That means that those houses have serious housing problems. They are below a reasonable level of thermal comfort, and they are not in a reasonable state of repair. And it is also claimed that UK has the oldest housing stock in Europe. It is estimated that nearly 40% of the houses were built before 1946. And we know that the age of house is the most important predictor of the housing quality. So in terms of the pathways linking housing quality and health, there are multiple pathways that have been identified. Vessels, which in turn leads to stress to the circulatory system, resulting in cardiovascular disease, for example, stroke. And we know that stroke is one of the main reasons people have functional limitations, have the progression of long-term care needs. Apart from that, so apart from the physiological pathways, in terms of cold houses, it can also have an impact in terms of causing worries about high energy costs, have a reduced feeling of control over their immediate environment, and have causing disruptions to sleep. All of this can have an impact on their mental health. And finally, there has also been research showing that if you have uneven floors and balconies, that can leads to a higher risk of falls, and that is also a risk factor of onset and progression of long-term care needs. So this graph is from one of the studies we published a couple of years ago. What we did was using ELSA data, we conducted survival analysis to look at the onset of long-term care needs. Our sample are 4 waves of ELSA data, and those people aged 80 and plus without any care needs. Then we look at people living in houses with different numbers of housing problems, the timing of having onset of care needs. So what you can see here is that even a particular age for people living in a house with more housing problems, the curve just declined more rapidly, which means that the onset of functional limitations of care needs just happen earlier in their life. So this curve is the top. You see it declines very slowly. This is a group of people at the starting point of observation. They have no housing problems. Their houses have no housing problems. So in ELSA, we also found a strong linkage between housing problems and functional limitations, that is the level of long-term care needs. Okay, so in this study, what we want to do is we make projections of long-term care costs for older people in England in the next 2 decades under different housing intervention scenarios. And because of the linkage between housing conditions and health, we have a hypothesis here is that by improving housing quality, we expect to see the future cost of long-term care will be reduced greatly. In terms of the data, we use data from 2 national surveys. One is English Longitudinal Survey of Aging, wave 6 to 9. We look at older people aged 50 and plus. The second, we also use data from Health Survey for England, 2011 to 2019. Apart from that, because we need to make projections at a macro level in terms of the aggregate cost of long-term care, we also draw data from population projections from the ONS, number of care users, that is formal care users, home care users, and care home users, published by NHS England and ONS. We also drawn data from the Office of Budget Responsibility, and they publish forecast on future inflation rates and the labor productivity. And we need the productivity because we need have a future trends in terms of the real cost of long-term care. And the long-term care is very labor-intensive sector. Labor productivity is one of most important indicator of the cost of long-term care. So in terms of the measures for ELSA, well, mainly we use ELSA to build a Markov model to make projections of future long-term care needs. We look at a number of variables here. The outcome variable we're focused on is the level of care needs, that is the number of ADL or IADL, activities of daily living, instrumental activities of daily living. In wave T+1, that is wave 7, 8, 9, and the key predictor of the level of care needs are the housing problems. There are 3 housing problems collected in ELSA, like damp, mold, condensation, excess cold, overcrowding, noise at wave T. So that is the main predictor. We also have included a number of control variables like age, gender, marital status, living arrangements, and most importantly, income, wealth, education, housing tenure, and also care needs at wave T. What we did with this data is we conducted time-lagged multinomial logistic regression model. We want to see for people with the different levels living in the house with the different numbers of housing problems, what their level of care needs will be in the future. And this is one way we try to disentangle the reverse causality problem. We want to be able to just entirely address that issue, but to some extent, it helps us to rule out certain reverse causality. And let me just go to this one. This is the Markov model we use. We have people with the different levels of care needs, low care needs, that is people with IADL limitations only, medium care needs, 1 ADL limitation, high care needs, 2 or more ADL limitations. People can transfer to different states over time. And there's a state mortality that people go into this state, they do not come back. So it's an absorption state, if you like. And to build this model, we rely on deriving transitional probabilities. That is, what is the probability of people transitioning from a certain level of care needs to another level of care needs, given their characteristics. And those transitional probabilities or transition matrices were derived from the ELSA data using the multinomial logistic regression. So it's basically the predicted probabilities going into the Markov model. So the way we did this is that we have ONS population estimates. ELSA tell us the proportion of people, the prevalence of care needs. Then we have a base year of 2022, how many people in different levels of care needs broken down by age and gender. We then apply those transition probabilities. We will know in the future, in the next year, what are the number of people with the different levels of care needs broken down by age and gender. And we do that repeatedly for 20 years. That is how we make projections for the number of people with care needs and the prevalence of care needs in the next 20 years. So that is, and also because we have the number of housing problem, this variable in the data set, we can also estimate for people living in a house with a different number of housing problems, what are their transition probabilities. Then we can use that to derive, if there is a scenario where, say, in the whole country, no one has more than 2 housing problems, what are the transition probabilities, and put it in the Markov model. Then we can derive the projected prevalence of care needs in the next 20 years. that is the output from the Markov model, and it will be the input of our next model, which is the macrosimulation model. For the macrosimulation model, what we focus on is to make predictions of demand of formal and informal care. And we use data from Health Service of England. Our outcome variable is receipt of formal and informal care. And we look at the number of drivers of care receipt. This is based on what has been already identified in the existing literature in different countries. For example, age, gender, care needs. Care needs is functional limitation, marital status, living arrangements, education, and housing tenure. And these are the steps of how we construct that model. We have a base year of 2020, and our starting point is a national population estimate broken down by age and gender. We then further break it down by functional disability, marital status, living arrangements, education, and housing tenure into 1,200 small groups, so that we can just approximately assume that in each group, the probability of or the propensity of receiving formal and informal care is very similar. Then we use regression analysis to estimate the probability of receiving formal or informal care in each small groups. And for each small group, we know the probability, we know the number, we multiply them, and we got the total number of people receiving formal care or receiving informal care. And once we got the total number in each small group, we multiply that by the average hours of formal or informal care. So that is hours of care per week. That gives us the total hours of formal or informal care per week. Then we multiply 52.1, 14 weeks, and then multiply the unit cost of formal care or informal care respectively. That gave us the total annualized cost of formal or informal care in the base year of 2022. So one point talking about, so we have, in terms of formal care, there's a price that we can observe on the market, but for informal care, we couldn't observe the price of informal care. There are 4 commonly used approaches to derive the unit cost. There's replacement cost approach, opportunity cost approach, contingent evaluation is willingness to pay or willingness to accept as us. What is the willingness to pay for an extra hour of unpaid care? And finally is discrete choice experiment, DCE, the so-called DCE. What we have used in this is simply just a replacement cost approach. We use the closest substitute as the unit cost of informal care, which is home care, which is £23 per hour. So that gives us the base year aggregate cost of formal and informal care. Then the last step is we multiply the future trends of the drivers of care utilization. So this flowchart simply just to summarize what I've just said. We've got the population, break it down into small groups, multiply the probability of using care, multiply hours of care, and then multiply the unit cost, and finally we apply the future trends. That's how we derive the projected cost, demand and cost of formal and informal care in different scenarios. And just to say that for future trends of care needs, as I have mentioned, we have the Markov model give us that input. So this graph shows the projection of the projected proportion of people without any care needs that are free of functional limitations in the next 20 years under different scenarios. So this black line here, this is the base case. That is, there's no housing conventions. What our projection is after we apply the transition probabilities in that Markov model, what we derive is that the proportion of people without any care needs will increase slightly from 0.66 to 0.67 between 2022 and 2042. So this is basically without any housing conventions. And in a scenario where no one has more than 2 housing problems, and it is this red line, and the proportion will further increase to 0.67. And this is yellow lines, the scenario where no one has more than 1 housing problems. It further increases to 0.68. And in this is kind of extreme scenario. No one, all of the housing problems is remedied somehow. And our projection is that the proportion of people without care needs in 2042 will be 0.69. And here, this is the projected prevalence of mild care needs. Mild care needs people with ideal limitations only. So our projection is that it decreases from 0.183 to 0.180. But in that extreme scenario where there are people have no housing problems, it decreases to 0.172. So similarly, for moderate care needs, if there are no housing problems, the prevalence of moderate care needs will also decrease in each single year in the next 20 years. This is mainly because of the more positive exposure to an environment where the housing conditions have changed. And this is the projected prevalence of high care needs. And one thing you have noticed is that this is not linear. The projection is not linear, especially in the first 10 years. Our projection is there's a quite deep decrease. And if you look at here, this is no care needs in the first 10 years. There's quite sharp increase. And the reason is that when we look at ELSA data, we see some cohort effects. That is younger cohorts, the functional limitations, they're healthier than the later cohort. For example, we have people from at the age of 60, and 10 years, we apply the transition probability, and 10 years later, they become 70 years old. And what we've got is that they are healthier than the 70 years old we observe today. So that's why we see the curve is sort of U-shaped, so it's not linear decrease or linear increase. So this is the projected number of formal and informal in the informal care. The blue bar is the projected number of formal care users. We project that we estimate that in 2022 there were around 300,000 care home residents, which is projected to rise to 390,000 in 2042. The red bar is home care users. 2022, we estimate there was 350,000 home care users, rising to 547,000 users. And then this is the projected number of formal care users in different housing scenarios. This is just in one single year, 2042. So this is the base case here. If we look at extreme case scenario, and in a no problem housing problem scenario, the formal care will reduce to 361,000 care home residents, and home care users will reduce to 519,000. This is the projected number of informal care users. These are all older people aged 65 and plus. 2022, we estimated that there were 2.2 million unpaid care users, which is projected to rise to 2.8 million in 2042. And this is a comparison of projected number of unpaid care users in different housing scenarios. If you look at scenario where no one leaving the house with housing problems. Our projection is that there will be around 2.7 million unpaid care users, which compares with 2.8 million unpaid care users in that year. So this is the projected costs of unpaid care and formal care. First, of formal care, our estimation was that in 2022, there were 22.4 billion pounds. That is the cost of formal care, which is projected to rise to 40.8 billion pounds in 2042. But if you look at informal care costs, it is much larger. And the main reason is that long-term care responsibility is still mainly assumed by unpaid carers rather than formal caregivers. And because we are taking the replacement cost approach, the cost of home care and unpaid care are both 23 pounds. This is simply just to help us to compare the relative order magnitude in terms of unpaid and formal care. So our estimation in 2022 is that the cost was 55.2 billion pounds, rising to 90.8 billion pounds in 2042. So this compares the costs of formal care in different housing scenarios. If we just look at 2042, this is base case 40.8 billion pounds. If you look at the no housing problem scenario, it reduces to 38 billion pounds in 2042. And similarly, in terms of unpaid care in 2042, the projected cost is 90.8 billion pounds, reducing to 83.7 billion pounds. So this is what we just use we take a multi-data set and a multi-model approach just to get these figures, and with a lot of calculation just to get these figures. That is, reducing housing problems, all of the housing problems could lower formal care costs by 2.8 billion annually in that year, in 2042. And for unpaid care costs, it will decrease by 7.1 billion pounds in 2042. This is what we just set out to do. By how much? Well, we know that it will reduce the cost of long-term care. We just want to know by how much. This is what we have calculated. So a summary of our research findings. We see from the data that people living in better housing conditions, they experience delayed progression of care needs. And based on our projection, we can see that addressing housing problems can alter the future trajectories of long-term care needs, especially in the no housing problem scenario. The prevalence of care needs in 2042 is projected to be 2.2 percentage points lower than the no intervention scenario, which translates into a reduction of formal care costs of 2.8 billion pounds and unpaid care costs of 7.1 billion pounds. I have just to say that because we are using the replacement cost approach, we got this number. If we use other approaches, this number will change. So it very much depends upon which costing approach we use. So we know that long-term care is a means-tested services. There are people who receive government support and they meet the eligibility criteria and they go through the means testing. And then other people, they are self-funders, they have to pay out of their own pocket. So there's government expenditure, there's private expenditure. So arguably, once we have, because of the improved housing conditions, we have the savings in terms of long-term care costs. For those part that is saved in terms of government expenditure, this can be used for other policy goals. For example, improving the quality of care and improving equal access of care and personalization of care services. And for the private expenditure, those cost savings probably means reduce the economic burdens for self-funders. And finally, we should not forget that there's a large number of unpaid carers and the demand for unpaid care reduces. That means less labor input for unpaid carers. which probably means that they can pursue their own career inspirations, or they just enjoy leisurely activities and so on according to their preferences. It's just some of the examples I can think, instances I can think of. And finally, I have to say that because we have done a lot of things in terms of long-term care, we should not forget the other side, that is the cost of housing interventions, and it's not cheap. And colleagues and I actually did a systematic review, had a literature review on this, and we have seen studies reporting the cost of intervention in different countries. But for countries outside UK, we just think it is not really that relevant to our purposes, because the cost of labor and capital in other countries can be very different from those in UK. And in the UK context, and the most comprehensive evidence base we have seen is the one published by Building Research Establishment, and they regularly produce a report to look at the cost of remedying all the Category 1 housing problems. So there's this housing and housing health and safety rating systems, and the Category 1 housing problems are those that is considered to have direct and serious consequences for individuals' health. So what they found is that if for all the Category 1 housing problems is remedied, that will cost £9.8 billion. So here are some of the main items. I think that the largest portion of the cost goes to excess code. That will cost £6 billion. Falls on stairs and between levels, repairing those will cost £1.5 billion. Overcrowding, £0.7 billion. Dampness, £0.3 billion. But still, if you look at £9.8 billion, that is the investment needed to remedy housing problems. But for the long-term care, this is not a one-off saving, because as we have seen, it just alters the trajectories of long-term care needs for the entire period of time. So we did some calculation as well. We know each year how much the savings in the cost will be in the next 20 years. So our calculation is that we also have to consider the discount rate. This is because £1 today is different from £1 20 years later, because I can use that pound to make investments. So we have to consider what the discount rate we will need to use to convert it, to convert the future cost to present values. So for example, if we just use 0% discount rate, our calculation is that the cumulative cost savings over 20 years will be £34.5 billion. This is way higher than, this is way larger than the cost of remedying housing problems. But if we change the discount rate, we got different numbers, and the 3.5% probably is a lot of studies use this discount rate. Our calculation is £23 billion. And in some cases, people may use 5% discount rate, that is £18.5 billion. And this is still higher than this is still larger than the investment needed to remedy the housing problems. And then another thing we considered is that once we put in the money, try to remedy the housing problems, it does not last forever. So we need to think about for how long it lasts. And we have a look at the evidence, how different housing projects can last. And if we make a very conservative assumption based on what is reported, that is, they last 10 years, which means that in the next 20 years, it will require around 20 billion pounds of investment. And then in some cases, the cumulative costs will not pay off, if that is. But in most cases, but still, I think in many cases, the cost savings of formal care will pay off the investment needed for remedying housing problems. And this is to say that we have even considered the cost of unpaid care. Yet this is just to compare the cost savings of formal care and the cost of housing interventions. So some final words in terms of the policy implications. There have been a lot of efforts around in the UK, I think, around the globe because of the population aging, how to address the rising demand for long-term care, how to identify effective measures, try to contain costs. And our message we want to get across here is the policymakers. I think that is important, but our message here is policymakers do not have to confine their policy measures just exclusively within the health system. And it might be helpful to identify synergies between health and other social policies. For example, housing interventions, it is an important remedying housing problems is an important intervention in the housing sector, but at the same time, it can be a very useful prevention measure in the health sector. So on that note,